Bismillah ar-Rahman ar-Rahim. Welcome back, everyone. Today we are going to discuss about an introduction to ICU Radiology, especially talking about the chest X-ray, how to read a normal chest X-ray, and how to spot certain pathologies. So this might take more than one video. Okay, so this is a normal chest X-ray. What really we are going to look at in the first instance is three things: penetration, inspiration, and rotation. A normal penetration of the chest X-ray, you should be able to see the spine through the heart, like so, like here. And a normal inspiration of the chest X-ray, you should be able to see at least 8 to 9 posterior ribs, and in this chest X-ray you are able to see 10. While a normal rotation, the spinous processes, like here, should fall equidistant between the medial ends of the clavicle. So these are the medial ends of the clavicle. So the distance between the spinous process and each medial end of the clavicle should be equidistant. Okay, so what's the problem with this chest X-ray? The problem is that this chest X-ray is underpenetrated. So how do you know that this chest X-ray is underpenetrated? You know that when you cannot see the thoracic spine through the heart, so the spine is not visible here. And actually, underpenetration introduces errors like the left hemidiaphragm may not be visible. You cannot see the left hemidiaphragm here. And this technical artifact could either mimic or hide true disease in the left lower side of the lung, which is like pneumonia or atelectasis or pleural effusion. The other problem that the bronchovascular markings of the lung tend to be more accentuated, which may give an impression that the patient is congested. So my advice is be careful for the underpenetrated chest X-ray, not to overcall a patient who is not congested to be congested. So now what do you think about this chest X-ray? So this chest X-ray is overpenetrated. And how would we know? You can see the spine, so that's not a problem. You can see the spine here. But overpenetration makes the lung markings difficult to see. And that might mimic some of the findings in emphysema and can be mistaken with a pneumothorax where you have jet black appearance. Here. So you might think that, oh, I can see only jet black appearance. This patient doesn't have bronchovascular markings. Then this patient might have pneumothorax, so be cautious not to overdiagnose pneumothorax in a patient who is overpenetrated, because to diagnose pneumothorax, you should be able to see pleural white line, and we will talk about that later. So how to know that your film that you are seeing is well inspirated? If you can count 8 to 9 ribs, then this patient is well inspirated. And here you can see 10 ribs, which is more than enough. So this patient is having a good lung inflation. So that's a normal chest X-ray. So suboptimal inspiration here. So what can we see? Only 7 ribs are visible in the frontal chest X-ray. So that indicates poor inspiration. And what is the problem of poor inspiration? So poor inspiration may cause crowding and accentuation of the bronchovascular markings at the basis, as you can see here. And again, crowding of the lung markings may mimic the appearance of aspiration pneumonia or congestion. So just be cautious, but more of an aspiration pneumonia because that's at the basis here, not around the hilum. Be cautious not to overcall an aspiration pneumonia in a patient who has poor lung inspiration. So again, testing the rotation of the chest X-ray. So the spinous process here should appear midway between the two medial ends of the clavicle. The problem with significant rotation that it may change the expected contours of the heart and great vessels and the hilum and the hemidiaphragm. So you have to just look at the spinous process and its relation to the medial ends of the clavicle before interpreting about the shifting of the airways. That's very important part. So if the patient is extremely rotated and you see the airway going one way or the other, just make sure that the patient is not rotated. And the best way to test the rotation is to see the position of the medial ends of each clavicle relative to the spinous process of the thoracic spine. So here you can see the relation between the spinous process and the medial end of the clavicle has changed. So it's more towards this side. So I will not talk which is which, like if it's rotated to the left or rotated to the right. That's not the scope of this lecture, but the thing is, if the spinous process is not in the middle between the two ends of the clavicle, then the film is rotated, then you cannot judge the position of the airway and sometimes the hilum. So that's just the first thing that you need to look at before interpreting the chest X-ray. Then talking about recognizing the normal anatomy of the chest X-ray, especially the pulmonary anatomy. So here you have the right hilum of the right pulmonary artery, and then here you have the left, and that's the main pulmonary artery in here. While this is the aortic knob, this one, and then you have here the ascending aorta here, this side, and the SVC is in this position as well. This is the right atrium. We'll talk about the pathology of the heart in the X-ray, and the ascending aorta comes here, left ventricle with the border in here. And then again, we talked about the head of the clavicle and its relation to the spinous process. And this is the trachea that you have to comment on. And we will talk about how to have a system in interpreting your chest X-ray in the exam, or even in your normal daily round, so that you have a system to look at the chest X-ray before saying a pathology. Here the Costophrenic angle bilaterally, and that's the hemidiaphragm. So we'll talk about that, that you should have a system while interpreting the chest X-ray. So talking about the normal pulmonary vasculature, the right lung is here, and in the upright position, the lower lobe vessels, which is in the black circle, are larger in size than the upper lobe vessels, which are in the white circle. And all the vessels taper gradually from central to peripheral, like this, with this arrow. So any change in the pulmonary flow or pressure may change these relationships. So you should find that lower lobe blood vessels are more accentuated and larger in size. Then talking about the cardiothoracic ratio, the estimated cardiothoracic ratio is that the widest diameter of the heart is compared to the widest internal diameter of the thoracic cage, which is this one. So that's the normal, that's the widest diameter of the heart, and that's the widest diameter of the thoracic cage. And usually you find the widest diameter of the thoracic cage at the level of the diaphragm, here. So the cardiothoracic ratio should be less than 50%. So anything bigger than that is considered that the heart has cardiomegaly. But just be cautious that the supine position may alter this ratio, but this is a relative ratio that you need to know if you are looking at the chest X-ray in general. But ICU patient who is supine, that might change a little bit because of the supine position of the patient. So again, talking about the appearance of the heart in the chest X-ray. So this is the location of the ascending aorta in here. So if you have dilatation of the ascending aorta, it will appear like this. And this is the contour of the left ventricle. If you have an enlargement of the left ventricle, it will appear like this. So for the ascending aorta, this one is the normal, okay? The yellow one is the normal, and it meets the contour of the right atrium in here. While this one is the dilated ascending aorta. And on the left here, this is the aortic knob. This is the main pulmonary artery. And the last contour in here will be the left ventricle. And for sure, this is the left hemidiaphragm with costophrenic angle. So this arrow represents a post-stenotic dilatation of the ascending aorta from a turbulent flow in a patient with aortic stenosis. Note that the cardiomediastinal or cardiothoracic ratio, like cardiac ratio to the whole thoracic ratio, is not big, it's not dilated, it's less than 50%. Because the left ventricle has left ventricular hypertrophy in the case of aortic stenosis. So that's not a dilated LV to cause increased cardiothoracic ratio. While here in this patient who has aortic regurg, you can see that the LV is dilated, and actually the ratio here is more than 50%. So that's a very important differentiating point between the valvular lesions. That this is an aortic stenosis patient, and it is less than 50% the ratio, with a dilated ascending aorta because of aortic stenosis, while this is the chest x-ray in a patient with an aortic regurg. So talking about the normal appearance of the heart and lung in the CT, this is the lung or the heart in the CT scan. So that's the aorta, pulmonary artery, LV, and RA. So it's important to have a look. That's a coronal plane as well, to have a look whether any of these are dilated if you have a CT chest. While this is the axial cut, this is the main pulmonary artery, and these are both branches, and the aorta is just beside it. And S here is the SVC. So this is the ascending aorta, and this one posteriorly is the descending aorta. And the black arrow is the left main bronchus, and the white arrow is the right main bronchus. Again, a coronal axial view for the CT chest. That's the trachea, right main bronchus, left main bronchus, and that's the bronchus intermedius. And this is the bronchus that's going to the right lower lobe. And this is the right upper lobe. This bronchus is going to the right upper lobe, while the bronchus going from the bronchus intermedius to the right middle lobe is not shown in this picture. And this is in the axial CT chest, right upper lobe, right middle lobe, and right lower lobe. While this is the coronal CT chest, upper lobe with the horizontal fissure here, and this is the right middle lobe, and this is the right lower lobe. This is what we call the 5 vessels view. This is the SVC here. This is the innominate. This is the brachiocephalic, and this is the left common carotid, and this is the left subclavian. And this white arrow is pointing to the esophagus. So this is the esophagus here, and this is the trachea. So another view, this is the AA, which is the aortic arch, this one. SVC. This is the azygos vein. And just notice that the aortic arch appears as a tubular structure with a similar diameter anteriorly and posteriorly. So this is an important differentiation, that the diameter here is similar to the diameter here. If you have an aortic arch dilatation or an aortic aneurysm, you'll find that this is dilated in one part. Here in this view, this is the ascending aorta, and this is the superior vena cava, descending aorta, and the P will be the main pulmonary artery. And this is called the aortopulmonary window level. And this is the trachea for sure. Then the main pulmonary artery level, you have the main pulmonary artery here, right pulmonary artery, left pulmonary artery, and this is the left main bronchus, and this is the right main bronchus, and ascending aorta with superior vena cava, and then descending aorta. So this view is axial view, and it shows the right atrium, and this is called the high cardiac level, okay? Aorta, RVOT, left ventricle, and left atrium. And you can spot dilatation of any of them in this view, and this is the descending aorta. And you can see the main pulmonary vein, which is this arrow, draining into the left atrium here. This is the low cardiac level, RV, RA, LV, septum, descending aorta, and this white arrow is the pericardium. So this concludes the initial introduction. After this slide, which talks about the left coronary artery. So this is the left coronary artery, and it divides immediately to the LAD, which is this arrow, black arrow, and the circumflex here, which is this white arrow. And again, SVC, aorta, RVUT, and left atrium. So I think this is enough for an introduction now, and then we can talk about the pathology in the next lecture. Aerospace diseases and interstitial lung disease. So all of that is from the point of view of ICU. It's not like a radiology professional lecture, but it's something for ICU doctors to try to get their head around the normal anatomy of the chest X-ray and the CT, and then we'll be talking about the diseases. Thank you.